this was cervical cancer. And then of course this is MRI section. So now coming to ovaries, normal ovaries I'll take. So normal ovaries, as we know, this is the anatomy of the normal ovary. It will measure what is the length of the ovary, I mean size of the ovary. 3 into 2 into 1 we take, no, like normally. So volume also we take like 3 to 5 cc's. That is volume. What you are telling is volume, 3 to 5 cc's. Otherwise, like at the most they will measure 5 into 3 into 2, but not normally. They measure always 3 into 2 into 1 in practice. So here we have taken only 2 dimensions, that is the length of the ovary. So how will you see the ovary practically? When you put a transvaginal probe, so how will you locate the ovary? So what we do is, like suppose the pointer is up and I am holding a transvaginal probe. So I have to go into the fornices, right and left. So when you go to right fornix and locate the right ovary, suppose I have put the probe like this and I have located the right ovary. So what I will measure now? The length and the height as shown here. Then I have to take the third dimension of the ovary, that is the width of the ovary. So what will I do? We don't have to turn like this 90 degree as we were seeing in the abdomen. So we have to just tilt like this. So we will take the breadth of the ovary like that. So here I have taken 3 dimensions. You can see length, height and width of the ovary. So now this is a sweep. I have seen the longitudinal section of the uterus. Then I am going into the right fornix. Here you can see the bladder anteriorly. Now you can see the right ovary. Nice follicle is seen in this patient. This is day 11 scan. And nice endometrium is seen like this. Now I have come to the left fornix and I am seeing the left ovary with a nice follicle. And you can see the nice fluffy endometrium here. So this is the long section as I have told you, and this is a comparison of a normal ovary with a polycystic ovary. This you know already. So this I have measured the polycystic ovary like this. So this is you go into the right fornix and you have taken the length and height, and then you turn the probe like this and you take the width, and volume here is coming as 12.3 cc, which is quite high. Also in polycystic ovaries, you can see the thick echogenic stroma here. So that is a characteristic of the polycystic ovary, that you can see a thick echogenic stroma and pearl necklace appearance. So the peripheral arrangement of these follicles in polycystic ovaries is characteristic. Now coming to the congenital malformations of the uterus. So they are defined as a deviation. So I'll not go into theory. I'll just move on. So they are defined as the deviations from normal anatomy resulting from embryological maldevelopment of Mullerian or paramesonephric ducts. Prevalence of the malformed uterus is 4 to 7% in general population and 15% in women with recurrent abortions. So they are associated with increased risk of infertility, then recurrent abortions, then premature birth, fetal loss, fetal malpresentations and cesarean sections. So they can be diagnosed on 2D ultrasound, HSG, MRI scan and during hysteroscopy or laparoscopy. And it has been generally accepted that 3D ultrasound of the uterus that we do to take a coronal section of the uterus is the optimal method to diagnose the uterine anomalies, and it is considered as gold standard diagnostic tool for uterine anomalies due to its high degree of diagnostic accuracy, less invasive nature and being comparatively less expensive. So MRI, when we do a MRI, When do we do MRI? Suppose we see on 3D ultrasound, we see a biconvate uterus. We think it is a biconvate uterus, but it can be uterus didelphys also. It can be bicolis. Yeah. Not just to confirm, actually, you can confirm the diagnosis by 3D ultrasound itself. But there are some cases where we need MRI. Suppose there is a biconvate uterus with bicolis, like two vagina are there. So we cannot find out by 3D ultrasound whether it is a didelphys uterus or a biconvate uterus. That time we have to, because we have to take into, and then sometimes in T-shaped uterus, dysmorphic uterus also, we have to do an MRI. So laparoscopy and hysteroscopy, they should be done. They are reserved for those anomalies in which we want to do a surgical procedure. Suppose we are thinking that it is a septate uterus. So what will we do? It is confirmed on 3D that it is a septate uterus. So we will do a hysteroscopic septal resection for a septate uterus. And if it is a biconvate uterus, then abdominal procedure has to be, metroplasty has to be done. So I think before doing these surgical procedures, we should be 100% sure that we are operating the patient, so she has this defect. So the non-invasive evaluation of Mullerian anomaly is always done by 3D ultrasound, and imaging of renal anomalies is recommended if a uterine anomaly is diagnosed. Always you have to look for the kidneys, bilateral kidneys. So embryology of uterus, I think you must have read. This is like, you must be knowing better than me. Pronephros and mesonephros and metanephros. Metanephros will give rise to kidney. So metanephros will be making kidney, and this nephrogenic bud, the lateral most part of the nephrogenic bud, which is lateral to the gonad, which can be ovary or testis. So here this is clear. This is the ventral development of embryo, and this is the dorsal part of embryo. Here you can see a nephrogenic bud. Medial to nephrogenic bud is the gonad, and this lateral portion of the nephrogenic bud, it is giving rise to the paramesonephric ducts laterally. So these are the lateral most part of the nephrogenic ducts. So they come from lateral to medial, like this. So these red structures, they are the paramesonephric ducts. They come from lateral to medial and unite in the center and go down, go down and sit on the uterovaginal canal, or what is known as the urogenital sinus. So paramesonephric ducts will give rise to, yes, uterus, fallopian tubes. So fallopian tubes are formed from the lateral most part of the paramesonephric ducts, which are coming like this. So these are the fallopian tubes, and they come and unite and they form a uterus in the center with cervix and upper 2/3 of vagina. So these are sitting on the urogenital sinus. So from this urogenital sinus, we are getting the sinovaginal bulbs, and from these sinovaginal bulbs is developing the lower part of the vagina. So I think it is clear to all of you. So uterus develops from the middle part of the Mullerian ducts after the fusion and canalization. So there are defects at different levels, which I will tell you. So these are uterine tubes, they are fusing here, this is sitting on the urogenital sinus here, and the lumen of the uterus is developing here, and finally the uterus, cervix and upper 2/3 of vagina has developed from this two paramesonephric ducts, which were coming like this. So abnormalities can occur at various stages of embryological development. That is, if suppose only one paramesonephric duct is formed. So what will happen? It will give rise to only one side of the, so only one paramesonephric duct is coming and it is developing into the uterus, cervix and the lower vagina. So that is called the uniconvate uterus. Now what can happen? Because these two ducts are fusing like this, suppose they do not fuse. So what will they form? This will form a separate uterus, cervix and vagina, and this will also form the same thing. So it will be uterus diadelphys, like failure of complete fusion. So complete failure of fusion, sorry. So biconvate uterus, there will be like these two ducts are coming, but they are not getting united in the beginning and then they unite. So the upper part will remain ununited and it will give rise to the serosal fundal indentation, or you can say a serosal fundal dip in this case, biconvate. That I'll explain later. So this is a biconvate uterus which is incomplete failure of Mullerian duct fusion. Like this we should remember. Then when they unite, this septum between the two ducts, it gets resorbed. Like it will disappear in some time. But if it does not disappear fully and remains like this only, the medial part of the paramesonephric ducts, then it will form a septate uterus. It will be a thick septum. Then you have to look later on for the vascularity of the septum, etc. And if it extends up till cervix, it is complete septate uterus, and it is when the septum is just above the cervix, it is called the partial septate uterus. So now there are three stages. One is formation, second is fusion, and third is resorption. So complete formation is there, means complete normal uterus is forming. Now this coming to the incomplete. So sometimes what is there is pronephrosis not developing. So there is no paramesonephric ducts, because from pronephros only nephrogenic bud will start. So there is no uterus. That is also called as MRKH syndrome. So what are the features of MRKH? Mayer-Rokitansky-Kushner-Hauser syndrome. So MRKH means absent uterus will be there and the secondary sexual characteristics will be present. So only one Mullerian duct is present, means uniconvate uterus. Then uniconvate uterus with a horn can be there, like this second paramesonephric duct. It has failed to develop. So it is remaining here. So it can be a communicating horn or a non-communicating horn. It can have a endometrial cavity. It cannot have a endometrial cavity. So four types are there in this. Then uterus diadelphys, as you know that these are developing independently, and this is complete biconvate where the fusion has occurred down, and partial biconvate uterus, then complete septate uterus, partial septate, and this one is arcuate. So I will go in detail of all this. So because of their clinical significance, it's important to diagnose and classify them for more effective and efficient planning of therapeutic strategy. So we should know that if we are doing a hysteroscopic septal resection, it is not arcuate uterus, it is a septate uterus. So for this thing, these classifications were developed. Also, to improve the reproductive outcome, suppose a patient is there with the uterine septum and you are doing a septoplasty, you are removing the septum, then she should conceive after that. So we should be very sure that how much we have to go and how much we have to resect the septum and how much we should leave. And also to minimize the complications and to prevent the inadequate surgery. So we should know properly which class this uterus belongs to. So first classification was given by American Fertility Society, and it was like hypoplasia or agenesis of uterus, uniconvate uterus second, then third is diadelphys, fourth is biconvate, fifth was septate, then arcuate, and then seventh was the DES or drug related or a T-shaped uterus. So these are the congenital malformations of the uterus we see in common practice. Like this is a normal uterus with a triangular nice endometrium, and this is a subseptate uterus. This is septate uterus. This is biconvate uterus, uniconvate uterus, and this is dysmorphic uterus or a T-shaped uterus. So can you tell me what are the characteristics of uniconvate uterus? Only one horn is developed. So what will we see on the ultrasound like?
Only one side fallopian tube plus a single cavity. Cavity can be very small.
Yes.
And
Definitely it will be small only, yes. So I'll teach you like the basic of this so that you can easily diagnose next time. So what we are doing is this 3D coronal section is must, that we know. So only on 2D we can only just suspect that two endometrium are, we can see two endometriums means there is something wrong. So we have to see this serosal fundus. This is outside, like the contour of the uterus. It is called the serosal fundus. And this one is called the endometrial fundus. Then the third thing is the intercornual line. That is the line which is joining the two ostia of the on the both sides. So this line is important. You must know. Then this angle between the two endometrial cavities. So this is these four things if we know, that is the serosal fundus, endometrial fundus, then this line which is connecting, and fourth is angle. That's all. Then you will aram se you can do. So now coming to the first, I gave the American Fertility Society classification. Now this is the European Society of Human Reproduction and Embryology and European Society of the Gynecological Endoscopy, ESHRE and SJ classification. This also became very popular, and it included the normal uterus as U0 class. Then U1 is dysmorphic, which contains a T-shaped or small uterus, hypoplastic, infantile. Then second class was the septate uterus, partial and complete. Then bicorporeal uterus with partial, complete and bicorporeal septate. And hemiuterus with a rudimentary cavity, communicating and non-communicating horn. Aplastic uterus with rudimentary cavity or a without rudimentary cavity. And the advantage of this classification was it included cervix and vagina also. So suppose there is a septate uterus. So septate uterus is complete. So what we will write? U to B. And the complete septate uterus means it is having a complete septate cervix also. So we will write U to B C1. And then if it is a normal vagina, we will write V0. If the vagina has a septum, it has a longitudinal septum, then we will write V1. If it has a transverse septum, we will write V3. So all the parts of the uterus are included. So this is very good class. This is a very good classification which includes the anatomy of the uterus, and it was given a lot of importance, this classification. So this is U2A partial septate, U2A complete, and this is bicorporeal septate. So this classification actually was developed to distinguish between a septate and a bicornuate, or a septate or a arcuate uterus. But there were some shortcomings in this classification also. This septate uterus, how it was classifying, like it was taking internal indentation, like the fundal indentation, which is more than 50% of uterine wall thickness. So what is uterine wall thickness? How do we take it? we take a longitudinal section of the uterus, then we take anterior myometrium, we take a posterior myometrium, we add it, divide by 2, that will be the uterine wall thickness. So indentation which was more than 50% of the uterine wall thickness was called as septate uterus in Eshrey-Sj classification. And the external indentation, which was a serosal indentation of more than 50% of uterine wall thickness, was taken as the bicorporeal uterus in this classification. So advantages were, the anatomy is primary basis for systemic categorization with the uterus as key organ. It is clinically oriented with prognosis correlating to the type and the degree of anatomical deformity. So this is the comparison, like Eshrey-Sj is taking the more than 50% of uterine wall thickness here, and this indentation is less than 50%, and American societies, what they are taking is they are measuring the dipping, like endometrial dipping, which is more than 1.5 centimeter, and they are also taking into account the angle between the endometrial cavities, which should be less than 90 degree. Then what happened is, another classification was given, that was congenital uterine and malformations by experts in 2018. Like this is the recent one. So it was developed, and it said that we will not take 1.5 centimeter indentation, we will take only 1 centimeter, that is 10 millimeters only, up and down both, like fundal serosa also and fundal endometrium also will take only 10 millimeters. So this was considered to be adequate. Why? Can you tell me, like what was the disadvantage in this classification? Why we had to take 1 centimeter instead of 1.5 centimeter? So you must go through this ECO paper, which was given by Ludwin et al. In 2019. So they have compared all the three classifications with their advantages as well as disadvantages. So what was happening is, like if it was arcuate uterus, this Eshrey classification was telling that it is a septate uterus. So prevalence was high. Suppose it is a arcuate uterus, dipping is only less, angle is obtuse. So they are telling, Eshrey classification is telling that it is a septate uterus because it is more than 50% of the uterine wall thickness. Then ASRM, what they are telling is, if it is indentation is 1 centimeter also, they are not telling it is septate. So they are not treating it. So lot of patients not treated. So how will they conceive? How will they be prevented from the pregnancy failures? So comparison. So Eshrey-Sj was over-diagnosing the septate uterus because the internal indentation depth was very small, whereas ASRM was underestimating the prevalence of septate uterus. So because indentation depth was more than 1.5 centimeters. So then came this QME, like congenital uterine malformations by experts in 2018. So they gave a medium criteria. Indentation depth was taken as 1 centimeter. So this is only followed. So QME gave a better criteria to distinguish between the arcuate and a septate uterus. Also, it gave 3 criteria which I will tell you to identify a T-shaped uterus. So T-shaped uterus is found in which patients? This is again ECO paper